Hello, everyone. My name is Sarah Z, and I am the Digital Marketing Specialist at School Health. I will be moderating today's webinar. To start off, I would like to thank you for joining us, and I hope that you find today's presentation informative. Clearly, this is a very important topic as we had over 720 people register. I know that for many of you, this will be your first webinar, so I will go over a few things that you should know before we begin. Our presentation today has audio and visual. Please be sure you are connected to both so that you can fully participate in the program. Our presenters plan to take about 45 minutes to present the material, after which we will take questions. We will not be taking audio questions, but we would like you to type your questions in via the questions box in your GoToWebinar interface. We encourage you to submit your questions at any time during the webinar. Please include the name of the presenter the question is intended for. This webinar is being recorded, and a link to it will be emailed to you for future playback. We will also include a copy of the presentation slides and your certificate of attendance, including your CE credit. You will receive this email in about 5 business days. And lastly, I would like to thank CSNO and your local School Health Territory Manager, Dave Cranny, for their support in bringing everyone together today to host this webinar. And now I would like to introduce our speakers and today's agenda. Our first speaker is Pamela Kahn, Coordinator, Health and Wellness at the Orange County Department of Education. She will be covering the new near vision legislation. Our second speaker is Dr. Sandy Block, a professor at the Illinois College of Optometry and the medical director for school-based vision clinics. She will be addressing near vision screening from a clinical perspective. And our final presenter is Dr. Kay Nottingham-Chaplin, who will speak about what tools are available for near vision screening. We have a lot to cover today, so with that, I will hand it off to our first speaker, Pam.
Good afternoon, everybody. We're happy to have you with us. This is a new challenge for all of us, so we're going to work our way through it and see what we can hopefully come out a little less anxious and a little more informed on the other side. The portion that I'm going to discuss today is, hold on, last slides. Okay. The portion that I'm going to discuss today is mandated school vision screenings, Senate Bill 1172, and the accompanying education code, which is 49455. And if you could advance the slide for me, please. Next slide. I'm going to go a little bit into the legal process, what happened. There were 2 bills proposed almost simultaneously in 2014, Assembly Bill 1840, authored by Campos, and Senate Bill 1172, offered by Steinberg. They were both on the legislative agenda. Both of these bills address the issue of mandated school vision screenings, including screening timing, methods, and the inclusion of near vision screening, which is what we are all kind of concerned about, especially. Both of these bills were signed by Governor Brown. AB 1840 was signed on September 29, 2014, and Senate Bill 1172 one day later on September 30th. Next slide. Since Senate Bill 1172 was signed last legislatively, this will be the bill that was implemented. Senate Bill 1172 incorporates changes to Section 49455 of the California Education Code. These changes were proposed both by this bill and by the Assembly bill. As I said, they were very, very near in their goals and language. Ed Code 49455 had been in existence already and did address our vision regulations, but this modified it somewhat. The changes to this Ed Code became effective as of January 1st, 2015, so we're about a month into it now. Next slide. So we're going to talk about what exactly Senate Bill 1172 described, and the Assembly Committee on Education that does an analysis of the bill as it's passing through. And here's what they said. The bill's goal was for early detection and prompt treatment of ocular disorders in children, knowing that that is important to avoiding lifelong impairment. The bill ensured that by moving up the time frame, and we're going to talk about what that time frame changed to, by moving up the time frame for vision screening in schools from 3rd to 2nd grade, vision deficits are identified before the crucial grade 3 milestone, which is identified by the research as the turning point for learning and during the key intervals that a child's eye is developing. So in other words, they felt doing it at 3rd grade, we were allowing too much time, too much water under the bridge, not enough time to modify and catch a child early and move ahead with their education appropriately. Next slide. This bill also added the requirement that nurses and teachers observe the appearance and behavior of students' eyes on a continual basis. Previously, only observation of the student's eyes, visual performance, and perception was required. So it expanded what we need to do, what we need to watch for on a continuing basis. Steinberg's belief was that near vision deficiencies may be interfering with a child's ability to read. So therefore, this bill also added in the requirement for near vision screening, which had not been a mandate previously. And the last bullet, as you can see, is an exact quote out of the bill. In addition, or out of the analysis, in addition, Senate Bill 1172 ensures that there is uniformity of training and methodology by requiring the California Department of Education to adopt guidelines to implement the near vision screening. Next. All right, so now we're going to go bit by bit through the Ed Code so you know exactly what's written and exactly what is expected of us. So who does this mandate that we screened? And here's where it changed some of the timing. We need to screen during the kindergarten year or upon first enrollment or entry into a California school district, and in grades 2, 5, and 8. And the appraisal shall be done by either the school nurse or other authorized persons under Ed Code 49452. Now you notice there's an asterisk on during the kindergarten year. A lot of questions come out on TK. Does TK count? And it's kind of small on my screen, but you can see the asterisk below that the California Department of Education defines transitional kindergarten as the first year of a 2-year kindergarten program. So if your district offers transitional kindergarten and you're having those little 4-year-olds come in for the first year of a 2-year kindergarten program, they need to be tested in that first year. They will not then have to be tested in the 2nd year of the kindergarten program because you've caught them in that first year, and that counts as their kindergarten screening. A pupil whose first enrollment or entry occurs in grades 4 or 7 shall not be required to be appraised in the year immediately following the pupil's first enrollment or entry. So if you've caught a kid and he came in at grade 4 for the first time to a California school district, you will not then have to do him or her again in the 5th grade. Now, we all know practically it's probably more work to kind of ferret out those kids that were tested previous years than to do them all, you know, in our mass screenings as we do. But the law says you don't have to. It is certainly okay if you do screen again, but you are not mandated to. Next slide. So what exactly are we supposed to screen for now? The appraisal shall include tests for visual acuity, including near vision and color vision. However, color vision shall be appraised once and only on male pupils, and the results entered into the health record. Color vision appraisal does not need to happen until the male pupil has reached the 1st grade. That is not a change. That has always been in effect. So that's sort of an update. Next. What about waivers? There are people that we know, parents that we know who don't want this done or don't want their children examined in school, and this Ed Code 49455 has an option for that. The appraisal may be waived. Oh, actually, this is a separate one. We'll talk about that one. This is a different one. The appraisal may be waived, meaning the screening. The screening does not have to happen if the pupil's parents so desire by their presenting of a certificate from a physician and surgeon, a physician assistant, or an optometrist setting out the results of a determination of the pupil's vision, including visual acuity and color vision. In other words, if a parent has taken their child already to any of the providers listed, physician and surgeon, PA, or optometrist, and the visual acuity and color vision were tested, they do not need to be tested in school. Again, unless the parent specifically requests or not, you can, but you don't have to. The parent has already fulfilled the requirements of getting their child screened. Next. Okay, how to do it. Now this one gets interesting. How to screen. A pupil's vision may be appraised by using an eye chart or any other scientifically validated photo screening test. Photo screening tests shall be performed, look at the red part, under an agreement with or the supervision of an optometrist or ophthalmologist by the school nurse or a trained individual who meets requirements established by the department. Please note that when the screener elects to use an eye chart and not use a photo screening test, there is no need to consider an agreement with or supervision by an optometrist or ophthalmologist. Now, what's causing a lot of concern is that red portion, under an agreement with or the supervision of. Everybody's wondering, what does that look like? We don't know yet. The California Department of Education has not issued any guidelines describing what that agreement should look like or what it should contain. I wish I could give you more information. We've talked with the Department of Ed, and they weren't ready to give us any information on that yet. So that's hanging out there a bit, and it's causing a little anxiety. I understand that, but we don't have any more information on that at this point. Next slide. There is a special circumstances. We get a lot of questions about kids who cannot be tested. They are nonverbal, there's disabilities, cognitively, etc. In the California Code of Regulations, which is referenced there are special allowances for that. That says for pupils who, because of age or special needs, are not able to be tested with an Optotype test, other types of vision testing, such as a functional vision test, may be utilized using procedures and criteria of failure as described by the manufacturer. And down below is a brief explanation of what a functional vision assessment is. It measures how well a child uses vision to perform routine tasks in different places and with different materials throughout the day. It paints a picture of how a child uses their vision and what visual skills they have and which ones they need to develop further. And certainly the experts that will follow me could do a much better job of explaining that. I just wanted to make the point that you do not always need to use an Optotype or a chart. There is allowances for kids who cannot be tested that way. Next. In this ongoing observation we briefly touched on earlier, that continual and regular observation of the pupil's eyes, appearance, behavior, visual performance, and perception that may indicate vision difficulty shall be done by the school nurse and the classroom teacher. And I know most of us have pretty good relationships with teachers. They come to you when they're concerned about something. Can we force them to? Can we tell them to? Probably not. They've got a lot to do. But like I say, our natural course of our day, we have established those relationships, and teachers hopefully are pretty schooled in that they need to let us know what's going on and we can help that child. Next. Okay, here's what I alluded to earlier as far as a waiver. If a parent does not want their child tested, they may file with writing that they adhere to the faith or teachings of any well-known recognized religious sect, denomination, or organization in accordance with its creed, tenets, or principles, depend for healing upon prayer and the practice of their religion. There is also a separate code that addresses parents who don't want physical screenings done of their child at all in school. So this particular section F was written into 49455. There is another ed code that parents can submit waivers or exemptions for physical screenings that they also don't need to be tested if the parent has done that as well. Next. This is the part that we're still waiting on. Ed Code 49455 now states that the department, meaning the California Department of Education, shall adopt guidelines to implement this section, meaning the whole code 49455, including training requirements and a method of testing for near vision. So take a look at the note below. As of today, the Department of Ed has not released any training requirements or recommended methods of testing for near vision, which is, like I say, what we're mostly concerned about right now, since their 2005 publication, A Guide for Vision Testing in California Public Schools. And I've put the link up there for those of you who maybe have not had a chance to take a look at that. It is a good document. It's helpful. It covers very comprehensively vision testing and screening in the schools, but it has not caught up with this new law yet. So we are still waiting for a few directions from the Department of Ed to supplement this new law 49455 that we are now operating under. Next. I put some resources here in case you're interested in looking up this information yourself. As I said, there are two bills kind of entered simultaneously on the legislative slate in 2014, AB 1840 and SB 1172. You can look both of the analysis and the text of both those bills up. I've put the web links there. I also put the link to find the actual ed code that we just talked about and went over, as well as, again, the Guide for Vision Screening in California Public Schools down there if you want to take a look at that manual. Next. There is my information. I've got a web page to take a look at. Give me a call anytime if you have any further questions. Next. And now I'm going to turn it over to Dr. Sandy Block, who is going to talk about the clinical perspective of visual acuity.
Good afternoon, everybody. First of all, I'd like to wish you well from very cold and snowy Chicago. So I wish I was with you and not having to deal with the single-digit temperatures. Let me just click on my arrow and, oh, so can you change? Oh, now I go. There we go. So I first want to do a disclaimer that gives you some insight as to my perspectives that I'm going to share today. My responses are based on various aspects of my professional life over the past few years. First of all, I have 30 years of experience as an educator in optometry, which really has allowed me to follow many of the changes and the improvements in vision screening techniques that have actually been seen over the years. There have been phenomenal amounts of work done, and it's been really exciting to watch. Second, I have watched to see in that research which ones are really considered the good screening techniques for specific problems, and actually many have been developed which are not. And lastly, I want to talk from my experience as a clinician. That really has the most significant influence on me. I've been practicing since 1981 with a focus in the area of infants, toddlers, children, and adolescents, as well as patients with special needs. And I currently am the medical director of a clinic that serves low-income children within the Chicago Public School system. We opened in 2011, and in the past 4 years, we've seen more than 23,000 children. So many of my comments will be based on that experience. So the question is, why are we testing vision up close? You know, that's certainly the big question of the day. We know that it really is important to be able to evaluate near visual acuity so that we can understand that the child's actually able to see the books clearly and the papers up close so they can perform their academic work. While there's no research to support it, we do assume that if a child doesn't see well up close, that they're not going to be able to be successful in school. What does near visual acuity really test for? You know, that's always the conundrum that we have. Vision screenings are designed to identify those children who are at risk for vision problems. The vision problems that you're looking for when you screen the vision of children in either a school or community-based screening looks for 3 primary things. The first one is strabismus, and you probably also heard it being referred to as a squint or an eye turn. And just to let you know, the eye turn can occur where an eye turns in, out, up, or down. You also are looking in your vision screenings to be able to see whether amblyopia has developed. And you're not necessarily testing for amblyopia, but you're testing for the factors that lead to the development of amblyopia. And amblyopia is also commonly referred to as lazy eye. Strabismus and amblyopia are different things, though oftentimes you'll hear people talk about lazy eye with a child who has an eye turn. It is not a correct thing. Eye turns are separate from amblyopia. And the last thing you're going to screen for are significant refractive errors. That is myopia, hyperopia, and astigmatism. Significant means that those refractive errors that would benefit from spectacle correction, or actually in some cases contact lenses are included. So include lens correction for significant refractive errors in this slide. I wanted to go into a little bit of detail about these three items because I want you to know when you screen what you're looking for. So strabismus, of course, is a situation where the eyes do not point to the same position in space. Obviously, as you look at these two images, you see the image on the left side of the screen, one of the eyes, specifically the left eye, is turning out, and actually the child is fixating with the right eye. In the right side of the screen, you see a child with an eye turn in on the left side. The reality is the children's eyes may or may not look like one is turning. Sometimes the eye turn is much harder to visualize because the amount of the eye turn is much smaller. The eye turn can also affect one eye or alternate between the eyes. In these cases, it's likely that only one eye is affected. But in some children, what you'll see is sometimes the right eye turns out, sometimes it's the left eye, making it a little bit more challenging to assess. If one eye does turn more than the other, and this has been occurring for some time, typically the vision in the eye that turns may not be as good as the other. And this is what leads to the lazy eye or the amblyopia. Near visual acuity does not specifically test for an eye turn, but it can identify if the vision in one eye is not as good as the other. But that's only possible if testing is conducted with one eye at a time, meaning monocular. That means you're covering one eye while the other eye is viewing the visual acuity target, rather than both eyes being open or binocular. Amblyopia, and I wanted to really point out a couple things because classically amblyopia is referred to a decrease in vision in one eye as compared to the other. In most cases that's probably true. When you see only one eye affected, it's usually due to a long-standing eye turn or a case in which there is a much higher refractive error in one eye as compared to the fellow eye. This is oftentimes very high nearsightedness or very high farsightedness in one eye only. Typically in cases of amblyopia, both distance visual acuity and near visual acuity is going to be reduced if amblyopia is actually present. There are also issues where eye health problems, such as a droopy eyelid, that means the lid goes down and actually covers most of the pupil, or a cataract in one eye, or some other types of opacity that actually prevents good vision from developing. Because in order for good vision to develop, the light needs to get in to the eye, be able to transmit through the visual system to the visual cortex in order for good vision to develop. But amblyopia can affect both eyes at the same time. It's rarely referred to, but that's the case when you have a child that is very significantly nearsighted or myopic, or both eyes are farsighted, or both eyes have significant amounts of astigmatism. You also have cases of amblyopia in both eyes when a child presents with such things as cataracts in both eyes. Congenital cataracts are not uncommon, are typically present very early in life. And the cataract actually has prevented normal visual development from taking place. I did want to point out here that amblyopia is not a disease process. It's almost like a diagnosis of exclusion. It occurs when an otherwise healthy eye actually is just not developing good vision because it received the right information to allow normal visual development. And it's diagnosed by ruling out any other eye health disorder. The last piece, and probably the most significant one when you're talking about visual acuity, is refractive errors. And I thought I'd go through the different types of refractive errors and how they would affect visual acuity testing. Myopia, or nearsightedness. This is a situation where typically distance vision is blurred, but near vision actually remains pretty good, especially in individuals with mild or moderate amounts of myopia. People with myopia typically are those that will complain about being able to see the board and they want to get closer. However, when you have high amounts of nearsightedness or myopia, you will often see not only the distance visual acuity affected, but near visual acuity may be compromised as well. Now, this is the assumption that you're testing the child without their glasses or their current prescription on. Hyperopia, or farsightedness, is very different. The effect is quite different than what you'd see in myopia. In these cases, you'll see near vision usually affected before any effect on distance vision. Visual acuity may be reduced at near when high moderate, that means the higher end of moderate, or high amounts of farsightedness are present. Children will typically complain of headaches, that you might see tearing or redness, they might talk about things being blurry intermittently, and those are usually associated with moderate or high amounts of uncorrected farsightedness. Children with small amounts of hyperopia or farsightedness do just fine and typically will be able to see well both far and near. Children who do have uncorrected farsightedness that does need to be corrected will oftentimes have difficulty concentrating for long periods of time up close. They're oftentimes the kids that can't sit still or start creating havoc because they're avoiding doing any close work. The last piece I wanted to add was astigmatism. Astigmatism actually occurs in isolation by itself, or you can actually have children that have both myopia and astigmatism or hyperopia and astigmatism. When a significant amount of astigmatism is present, both near-distance visual acuity testing and near visual acuity testing will be affected, and typically at the same amount. Children with significant amounts of astigmatism typically have learned to compensate for this by squinting. So those are your kids, we often see children with myopia squinting for distance viewing, but children with high amounts of astigmatism will look both far and near by squinting. So when you do any type of visual screening for visual acuity testing, you need to watch your child closely to make sure they're not squinting when you're doing your testing, because it will overestimate what they're capable of seeing. Note that you might find interesting is children from Hispanic backgrounds have been shown in the research to have much higher amounts of astigmatism, and oftentimes amounts significant enough to lead to amblyopia. So when you see somebody squinting, obviously they can see better with squinting, but that's really not the way we want them to see the world. The last thing I wanted to kind of throw in here is accommodation or focusing. Focusing is really accommodation is the difference between when you look at something far away and you change your focus to something up close. There's a certain change that takes place in the eye, and we call that accommodation. As we approach 40 or older, that kind of goes away and you replace it with reading glasses. However, in children, this should be a normal response for them to be able to do and totally involuntary. There are some children who do have accommodative systems that are not working properly. These children may report initial blur when they change their viewing distance from far to near or from near to far, but typically we'll be able to clear it up within a few seconds. Children with farsightedness that's not corrected have to compensate for the farsightedness as well as if their focusing system is not working properly. They are really the ones that are complaining about being tired when they're doing any close work, have headaches, or may actually say the words go in and out of focus. Kids with these kinds of problems oftentimes will have challenges academically performing well when they're doing a great deal of close work. So let's talk about the screening test, because that's often the issue. The best practice is when you're doing a vision screening test is that you have tests that follow these guidelines. Number one, they have high sensitivity. That means they fail children that only have a vision problem. So somebody with high myopia, you want the distance visual acuity test to fail them for that high myopia. You want it to be highly specific. You want to pass children who have no vision problem, and you want it to be valid. A test needs to be able to test what it says it tests. So for example, children with myopia, significant amounts, you want it to be able to show a failure in a preschool feet and a failure for older children at 10 feet. Otherwise, it's not really telling you what it says it tells you. So it's really important to have good tests that have high sensitivity, high specificity, and are valid tests to be able to get accurate results. The California screening requirement basically says, and I'm just reiterating very quickly what Tam said, that children need to be tested upon entry to school and on a period of every 3 years. Typically that would be K1, 2nd grade, 5th grade, and 8th grade. The screening should also be done if a vision problem is suspected, if school performance is down and you suspect a vision problem. And teachers are great referrals. They're the ones who really will identify if a child's having some difficulty visually when they're doing their schoolwork. Uses an optotype at distance, such as letters for your literate students, and for your pre or your illiterate students using an E, HOTV, or the Leah symbols with crowding bars. Those children who are unable to be tested or have special needs and can't do the other tests should do the functional vision test that Pam was referring to. And the pseudo-isochromatic plates for color vision is the recommendation. And anybody who fails should be retested, because oftentimes it's a learning process for some of the younger children. Why is the recommendations for these grades? And I thought it would be helpful for you to understand that rationale. For the kindergarten and the 2nd graders, the rationale for screening these younger children is for looking for existing amblyogenic risk factors that we talked about, like significant refractive errors or eye health problems. For the older kids, the 5th grade and the 8th grade, the rationale for screening the older children relates vision changes over time. The research has shown if somebody is going to develop myopia or nearsightedness, you might not see it until the age of 9 or 10 years of age. And actually, the most significant studies were done in California and Orinda. Also, this is a good time to find out if the recommendations from the earlier vision recommendations were followed through with, because we often know that parents don't always follow through with our recommendations and that some intervention has been done. So near vision testing, when you are doing a near vision test, though the guidelines have not been written, you really do want to follow some specifics. The charts need to be properly designed. You don't want to isolate letters or symbols unless you have crowding bars around the letter or symbol, which would give you a more accurate test. You want to watch the child very carefully when a child is not seeing well when you're doing near visual acuity test. What happens is they will try to move closer to the target. Kay's going to show you some ways to monitor that. As they move closer to the target, there's a certain amount of magnification that takes place, and the image gets larger, and obviously they're going to be able to read smaller lines. But the information's not going to be accurate. When you're testing monocularly or one eye at a time, you want to watch for peaking. Children want to do well, so they're going to use their better seeing eye if they don't see well in one eye. They're going to try to use the better seeing eye to be able to see smaller and smaller targets. And also, one of the things that's very rarely focused in on is you want to ensure that the front surface of the card where the symbols are actually has good lighting. I don't care whether the eyes are well lit. I want to make sure the chart is well lit so the child can actually see the target. Other things to think about is when you're testing near visual acuity is if amblyopia is present, you need to be able to test each eye individually. That's the only way you're going to identify if the risk factors for amblyopia are there or amblyopia already exists. If you test both eyes together, you will miss that entirely. So here are the referral criteria. On the left side is the California referral criteria. On the right side is the National Center on Vision and Eye Health from Prevent Blindness. This is made up of an expert panel that was brought together. The 6-year-olds and older is about the same. If the visual acuity is 20/40 or poorer, then you are going to refer the child. For California, you see 20/50 or poorer. For children less than 6 is a referral criteria, and any difference between the eyes of 2 lines or greater should be referred. However, you'll notice the National Center has a variation that if the vision is poorer than 20/40 for 4-year-olds, that's a referral. If the visual acuity is poorer than 20/50, for 3-year-olds, it should be referred. So it gives the 3-year-olds a little bit more leeway. The next piece that's been added is the testing for hyperopia. And I wanted to include this because it is not a near visual acuity test. When you test for hyperopia, what you're doing is you are using a distance chart and doing your regular distance visual acuity testing, one eye at a time. And then you're interposing a +250 lens in front of the eye over the distance visual acuity chart. You're still at the same distance, whether it's 5 feet or 10 feet. If the vision with the +250 lens is as good as it was without the 250 lens or better, that suggests that the child might be farsighted or have hyperopia. It is not a near visual acuity test that when you use the +250 lenses. There's also pieces that we are seeing now with new technology, some excellent tools that are out there. It's brought new means to screen children's vision, and the acceptable devices include the SureSight, the Plus Optics, and the Spot. These instruments are actually excellent additions to our cadres of testing, but we really need to remember what they're telling us. These devices are often preferred for screening children with special needs or those who are unable to complete the typical visual screening technique. So here is the SureSight. It is designed to test for significant refractive errors one eye at a time. It does not look at a difference in visual acuity, nor does it test visual acuity at far or near. It is best to be used along with stereopsis testing, so you're looking to see if the child is using both eyes together. The test here I show is the PASS test, and it's a forced choice test that can be done on preschoolers, elementary school, or high school students. It has various levels of acuity, stereo acuity that you can test. The Welch-Allen SureSight was recommended by the Vision and Preschoolers study at a 90% specificity, which is excellent. The other two devices are a little bit different. Here is the Spot. The Spot is done at about 1 meter away from the child. The nice thing about the Spot is you have a nice place where it tells you whether the child should be heard or not. And you don't have to worry about the amount. The instrument is set to be highlighting what should be referred and what shouldn't, but it does tell you that the child should be referred. It also gives you the impression of whether the eyes are postured straight ahead. So instead of using the stereo acuity test, this does both. So it provides you a combination of information. The Plus Optics test also does the same thing. This is an example of an earlier version, but I wanted to show that because it shows the distance between the child and the technique and the instrument, and it also shows you the front of the instrument because it shows what the child's looking at and gives them some the lights flash to keep the child interested, and it tells you at the bottom of the form whether the child should be referred or they pass, and at the top of the form it gives you some indication whether the eyes are postured together. You do not have to worry about the numbers. You are just looking at whether the child is referred. The screening instrument is set up very clearly to be able to show who should be referred and who shouldn't. So those are the things that I wanted to share, and if you need any more information, here is my contact information, and at this point I'd like to transfer it over to Kate to give you more information about the actual tools that you'll be able to use.
Okay, hi everybody. Glad you could join us. So I am going to be talking about the tools and then we will take your questions. So first of all, I wanted to share with you that for Optotype-Based screening or your test of visual acuity, the National Expert Panel of the National Center for Children's Vision and Eye Health to Prevent Blindness, the American Association for Pediatric Ophthalmology and Strabismus, and the American Academy of Ophthalmology all recommend Leia symbols or the HOTV optotypes. For older children, I'm just way moving ahead of myself. Hold on. For older children, the American Association for Pediatric Ophthalmology and Strabismus recommends Sloan letters. This would be your first chart. The American Academy of Ophthalmology recommends Sloan letters or Leia numbers. And these are just the optotypes, not necessarily the format that they are provided in. So if you happen to have a light box, and this is the newer version of a light box, this is the ESV1200 with LED lights, much brighter than your Model A or some of the other older models because of the LED lights. Gives you better lighting across the face of the chart. So you have Leia symbols, Sloan letters, and Leia numbers available for the ESV1200. Then if many of you in California use the Instaline, there is a chart with Leia symbols that has distance and near on the same chart. If you, now Sandy was talking earlier about making sure that your distance is correct and that children who maybe have some problems seeing will try to move closer to the chart. These charts, if you notice, have this 16-inch cord that goes from the temple to the chart. So you would place the one end of the cord close to the temple area, and that will maintain your 16-inch distance. So this is an example of a Leia symbols. On the other side that looks like words, you have 25 and 50% spacing. Another example of Leia symbols is in the middle, and then HOTV is on the right. And some of you were talking about concerns about doing near and mass screening. You can do the near charts like you do the distance charts, where instead of having the child read every single optotype, you can start at the top asking the child to identify the first optotype on each line until they miss an optotype, then move up to the line above the missed optotype and do every optotype on that line, moving down the chart until the child misses 3 or more, and then the line above that would be the actual visual acuity for that eye. So you don't have to do every single optotype, which I think you may fear would slow you down. So other examples for older children, and then a mixture of the two. This is a Sloan letter chart. This one I like because it gives you two different sets of Sloan letters, so you could use one side for regular screening and then use the other side when you're doing a rescreening, which should occur within 6 months of failed screening. Then the one in the middle would be Leia symbols. Again, the typical eye chart. Okay, then hold on. I'm getting very happy with the arrow keys. You have your regular chart here, and then the 50%, 25% spacing on this side. Then the one on the right has Leia symbols on one side, Leia numbers on the other side, giving you the combination if you didn't want to have separate charts, or you just like the idea of having numbers and symbols, the Leia symbols. So these also come in kits. So this is a fairly new kit from the American Association for Pediatric Ophthalmology and Strabismus. It includes color. It has symbols for younger children until they know their numbers. It has stereo acuity. It has near here, and then it has occluder glasses for the near chart. for younger children and for older children. Then the chart on the right-hand side has been around for a while. That is the near-distance vision screening test with the tutorial DVD from APOS, Good Light and School Health, which has Leah symbols, HOTB, Leah numbers, and Sloan letters. So this one is a combination of distance and near. Now APOS also has a basic kit that does include distance. And so many of you who've heard me before have heard me talking about pointing. No matter which chart you should use if you're doing a test of visual acuity for optotype-based screening, you never, ever, ever point and hold your pointer at the optotype. The World Health Organization says it is okay to point line by line, but not optotype by optotype. But we know with younger children, sometimes they get lost, so you can point beneath or over top the optotype, quickly remove the pointer just to show the child which optotype to identify. This chart does not have a box around the lines. If you're using a chart that does have a crowding box, you would never break that box. Again, you would just point below or above at the optotype and quickly remove the pointer. Okay, occluders. Wow, moving quickly. Sorry. Okay. So for children 10 and younger, age 10 years and younger, the best practice from the National Expert Panel for the National Center would be these adhesive eye patches. These occluder glasses on the right are acceptable, so you could use either one for occluding children less than 10 years, and then for older, what is absolutely unacceptable according to the National Expert Panel, the National Center for Children's Vision and Eye Health, for children ages 3 years through 5 years, unacceptable occluders would be hands, tissues, paper cups, or cover paddles. And when I'm talking about cover paddles, I'm talking about what I call lollipop occluders, which are acceptable for 10 years and older. Another occluder, which I particularly like, would be what I call my Mardi Gras mask. So the Mardi Gras mask can flip from eye to eye by just turning this handle, and that again is for ages 10 years and older. So going back to the devices, now the legislation talks about photo screeners, and while the Sure Sight is included, it's actually an auto refractor, so I'm not quite sure how this will come out when the guidelines are. But the three instruments, or the three devices that are recommended or designated as acceptable or best practice from the National Expert Panel to the National Center would be, again, the Welsh-Allyn Sure Sight, version 2.25, the Welsh-Allyn Spot, and the Plus Optics. So those could easily take care of the option you have for a test of visual acuity, which would be to use an instrument. And this would be my contact information if you have more questions. That's a lot of information, but you will have handouts coming in 3 to 5 days that you can look at these tools again. So thank you, and now we're open to questions.
Great. Thank you so much, Kay. We had a lot of questions come in already. We will get to as many questions as we can. But we will have a record of all the questions asked, and we will do our best to follow up with everyone afterwards if we cannot get to your questions. So there were a couple of questions that came in during your presentation, Pam, so I thought we could start with those. Just a few clarifications on the waiver aspect. It said physician and surgeon. Did that mean someone was curious, was that meant to be physician or a surgeon?
That's how we've always read. Yeah, that's written in a few other places, and we, our legal has always interpreted it to mean either or.
Sure. Okay, great. And then Gina asked, is a nurse practitioner allowed to do the vision screening?
Well, you mean, well, certainly a nurse practitioner, if they're a credentialed school nurse, is allowed to do the screening. A nurse practitioner, if you're talking about can they do it and bring it in and then we don't do it in the schools. Remember that was that waiver mentioned in the legislature? A nurse practitioner was not listed as one of those health practitioners who could do it outside the school environment, have the parent bring in the results, and then we wouldn't have to test them in the school. They were not listed as one of those providers.
Okay, good. Thanks for the clarification. And then Kimberly asked another question on the waivers. Does this mean we can require a note from the healthcare provider if parent waives school screening? And will we be audited and found in default if the waiver is not obtained, if the parent will not bring anything from the physician? So,
no,
if a parent question.
Yeah, if a parent does, there are two ways that we wouldn't have to do the vision in the school, vision screening in the school. Number one is, as we just discussed, if the parent has the exam done outside of the school by one of the practitioners listed in the ed code and brings the results in. The school is not obligated to do any further screening. The second condition would be is if a parent brings in writing, and I looked it up, it's ed code 49451, if a parent in writing states that they do not want their child tested. That is sufficient. They do not need anything more from their healthcare provider. So either they bring results in from a healthcare provider who has done it already, or they simply state they don't want their child screened. Those are legally acceptable methods of the school not having to do the screening, the mandated screening.
Great. And then Esther wanted to know, is grade 10 no longer required?
Grade 10 has not been required. I think that came about, a lot of us have been doing grade 10 for years, but if you even look at ed code 49455 previous to this new modification, it only went up to grade 8. Grade 10 is required for hearing screening unless you file a waiver with the state. So I think many of us just went ahead and paired the two and did hearing and vision all the way up to 10th grade. But ed code 49455 has always ended its mandate at the grade 8. So this is no different. Some of us just really weren't aware of that.
Okay. And then another question was, do these new regulations apply to preschool programs such as Head Start?
These are written, the ed codes are written for K through 12.
Okay. And then one last question, I think along those lines, I believe it was answered, but just to clarify, what is the best practice for the time frame for retesting?
I think Kay addressed that, and she said within 6 months.
6 months, right? Okay, great. And then let me just see what else we have coming in. There was a question addressed to Dr. Black, and it is, what evidence is there to support that children need to be screened for near vision in school?
So the reality is there is very little evidence, scientific evidence, to say that if a child passes or fails that there's a specific vision problem. And that is one of the challenges. Most of this comes from clinical interpretation and the fact that children spend a great deal of their day focused up close, and we want to ensure that children actually see well when they're doing their reading or other book work.
Okay, great. And just to let everyone know, a couple of people did ask, everyone will receive a copy of the PowerPoint presentation in the follow-up email that will come to you in about 3 to 5 business days, along with a copy of this recorded presentation and your CE certificate. So I just wanted to clear that up for everyone. Let's see. There were some questions about using the point .250 lens. So here's one. For Dr. Block, there are opinions out there that using the .250 diopter, forgive me if I'm pronouncing that wrong. With the
You're correct.
This is, okay. This is big. So let's, with the 2030 line, a 10 feet 10 distance would qualify as near vision screening. It looks like that is not accurate, and why? That's a question from Liza.
So typically, using the plus lenses, it is done at a distance task, and it is not looking at how a child sees up close. It's just looking to see if farsightedness is present or absent. If the acuity is the same or better with the plus 250 lenses at a distance target, it doesn't tell you anything about the near visual acuity.
Okay, and then there was a question about, her question continues to ask about the tumbling E chart. It was referred to as obsolete. Could you please clarify if this refers only to the 3 on a line chart or to the crowded E, 1 on each line as well?
So I'm
Is this appropriate for younger students and illiterate students still?
I will be happy to take that one. This is Kay. Hi. So the tumbling E is no longer recommended in any of the national guidelines that are current, because with the tumbling E, you're asking children to give you orientation and direction. That is a cognitive skill that emerges over time, and it does not occur in preschool age children or your kindergarten children. Up and down comes in first, followed by left and right. Up until around ages 8 or 10, you're actually testing cognition and not vision. And then some people will say, and I tried this in an eye exam, and it is true, when you go down on a chart until you are at threshold where you can no longer distinguish one from the other, you can look at the dark side of the E and the broken lines and guess at the direction of the optotype, and one of the national and international guidelines for eye chart design is that the optotypes be almost nearly equal in legibility, that one is not any easier than another to identify. Hope that answered your question. Thanks.
Thank you, Kay. Well, there's a lot of questions coming in. I'm going to address one more question, and then unfortunately we're at about time. But as I mentioned, I want everyone to know that we will review all of the questions that were asked today, and we will work with our presenters to answer them, and we will work to share them with the group or on an individual basis as appropriate. So the last question is from Kathy, and she asked about muscle balance and binocularity tests. Are these to be included in vision screening?
So are you talking, the question is that from a legal standpoint, from the protocols that the guidelines say, or I would think that, Pam, that might be your question.
Okay, well, you know, it was spelled out. Muscle balance is not spelled out in the ed code as a requirement. Color, acuity, near vision, et cetera, is. Muscle balance is not. And I'm sorry, what was the other one that she was asking about?
Binocularity.
Yes.
Oh, binocularity. Well, that's a method of testing, and I think our experts can address that. But as far as muscle balance, at least what we know so far, until the Department of Ed puts out regulations, that has not been included as a mandated portion of the testing. It may well be a very good idea, and I'll let our experts address that, but it is not mandated.
So this is Dr. Block. It would be very valuable to look for muscle balance. And when you do the Sure Sight, I showed you that in addition to doing the Sure Sight as a technologically savvy way of getting a good screening for refractive error, you should pair it with a test which assesses whether the child is using both eyes together. And while it doesn't necessarily say muscle balance, it alludes to the fact that both eyes are working together, and that would suggest if they can't see the target, that the eyes are not working together. Sort of it's a big jump, but that's oftentimes what's used in vision screenings to assess whether the eyes are working together well, whether it's strictly binocularity or strabismus that we're looking at. I'm not sure if that's sufficient. The code does not include any additional references to stereopsis testing, though the past test has really been one of those that were recommended by the National Center to be used. Because visual acuity alone only looks to see how well you see out of each eye. It doesn't tell you whether you're using both eyes together. In an ideal world, it would be appropriate to pair the visual acuity testing with a test of stereopsis.
Okay, well, it is 5:30. There are a lot of great questions that we will be following up with. But I would like to be respectful of everyone's time. So we definitely packed a lot of information into 1 hour. I hope everyone found the information that was presented today very useful. I would like to thank our presenters, Pam, Dr. Black, and Dr. Chaplin for sharing their knowledge and resources with us. Thank you again to CSNO and to Dave Cranny with School Health for their support and hard work in bringing this webinar together for everyone. When we close the webinar today, you will have the option to take a very brief survey. And if you don't mind just taking a moment to share your feedback with us, we would greatly appreciate it. We do review all of the feedback. And just a reminder that that follow-up email with a link to today's recording, presentation slides, your CE certificate, and some additional resources, that will be coming from us in about 3 to 5 business days. It takes us a few days to compile all the information and get it out to you. And that wraps up our presentation for today. Thank you. Enjoy the rest of your afternoon, and this will end today's presentation.